Hello everyone. My name is Harshini Anand, and thank you so much for joining us today for Undue Medical Debt's Young Adult Voices on Medical Debt networking event. Um, Undue is a nonprofit dedicated to eliminating the issue of medical debt in two major ways. First, by erasing debt directly, and second, by advocating for systemic policy change, focusing on different policy efforts such as in strengthening hospital financial assistance programs, increasing billing transparency, and protecting patients from aggressive debt collection practices. Since its founding, the organization has relieved over $20 billion in medical debt for over 13 million people. This event specifically is part of our Students in Action campaign, an initiative designed to engage young people in the movement to end medical debt and build a more equitable and accessible healthcare system. It offers students the chance to learn more about the medical debt crisis, take action through advocacy and organizing, and lead independent fundraising efforts to support Undue's mission. We're especially grateful to our generous donor sponsor for making this event possible. Today, we're joined by an incredible panel of experts whose work ranges from clinical settings to legislative halls to address the root causes and human cost of medical debt. And I'm really excited for this conversation that we're about to have. I guess to start, could each of the panelists briefly introduce yourselves and share what you're working on right now?
Hi, everyone. My name is Jennifer Holloway. I use she, her pronouns. I am a staff attorney at ZEDEC DC. ZEDEC DC is a nonprofit legal services provider that helps DC residents with debt-related issues. I specifically lead our medical debt work, so I provide free direct services for DC residents, helping them navigate medical debt. And we also do policy advocacy, specifically focused in DC on, changing things to have more protections for folks with medical debt. And last year, we worked with Undue Medical Debt on a debt cancellation campaign. So we worked with the DC government to have a statewide grant for undue medical debt to purchase and cancel debt for DC residents.
Hi, everybody. My name is Marcella Lampone. I use she, her pronouns, and I'm a policy and project coordinator at Healthcare for All of Massachusetts. We're a nonprofit consumer advocacy organization that's promoting health equity and aims to ensure that everybody in Massachusetts has affordable and also comprehensive healthcare. And we do this through a variety of methods. We have a direct service helpline that's helping people get insurance. We have a community engagement team, and then we have a policy team, which is what I'm on. And my role specifically focuses on medical debt policy. So right now, Healthcare for All is part of a larger project that was funded by the Atrius Health Equity Foundation to eliminate medical debt in Eastern Massachusetts. There are 3 different organizations as part of this project. Undue Medical Debt is one of them. And then Health Law Advocates is a sister organization of Healthcare for All. So they provide free legal health assistance to low-income individuals. And then Healthcare for All's job on the project is to subgrant community-based organizations that are helping clients with medical debt and like providing referrals to health law advocates, and then also to stand up our policy agenda for Massachusetts. And so we helped earlier this year, lawmakers in Massachusetts proposed 3 different bills related to medical debt. The first bill is on things like protections for people who already have medical debt. So protecting them from aggressive debt collection practices, like making sure that their credit score doesn't tank because they have medical debt, or making sure that that their like primary home isn't taken because they have medical debt. And then we have a bill on financial assistance policies in hospitals. And then we also have a bill on the health safety net in Massachusetts, which is kind of like a mix between health insurance and hospital financial assistance. And both of those would help prevent people from getting medical debt in the first place. So that's mostly what we're working on right now.
Hi, my name's Hadi Farid. I use he, him pronouns. I'm currently a graduate student at Harvard studying educational policy. I've worked in health advocacy for about a couple of years. I'm mostly involved as a national advisory board member for Young Invincibles. Young Invincibles is basically a non-policy advocacy organization that's basically used to get young adults around the age of 18 to 34 to be more focused in key issues such as higher education, healthcare, employment, and civic engagement, and just getting more young individuals more involved in policy. Right now, I'm basically working on press conference to highlight the real impact of medical debt for young people, especially how it affects decisions around healthcare and education and even career choices. I'm also involved in a program that trains young adults to engage in policy advocacy. It's called the Youth Advocate Program, and we take in 18 to 20 young individuals who want to be more involved in health policy, and we basically train them and teach them the basics of policy and just try to get them more involved and teach them to be leaders in their community.
Hi, I'm Serena. I'm a medical student at Harvard Medical School. I'm doing my MD, MBA, so I'll be going to business school next year. I've spent a lot of my time in college in Baltimore and also in medical school, really understanding how patients in more vulnerable communities experience healthcare access and healthcare equity. I'm working on a project with Ria, who's on this call, on understanding financial assistance programs across Massachusetts hospitals, both on a policy and just like subjective and objective wise, what exists in Massachusetts for patients experiencing medical debt or medical financial burdens.
All right, awesome. So the very first question that I have is, how did you arrive to your current position, and what kind of drew you to that line of work? So Jennifer, again, if you want to start.
So I started this job right after law school, and I started as an Equal Justice Works Fellow. And that is a type of fellowship for recent law school grads to work on some sort of project within an organization that's specifically like helping people in some way. And I have done a lot of economic equity work in the past. So I was really interested in how medical debt fits into that. Um, when I was in college, I had cancer also, and I'd traveled to Boston for treatments, and I was enough to have good health insurance coverage and parents that could help. And so I wasn't burdened with medical debt, but I know that's very unique. And so I'm grateful to be in this position to give back.
Yeah, so I kind of have a really long story for how I got to my role, so I'll try to keep it short and brief. But I actually graduated college in 2020 with a Bachelor's of Science degree in biology, and I really never wanted to work on policy or politics. I thought that that would be like the worst job I could possibly have. And so out of college, I got my first job and I was working in a lab doing infectious disease and genetics research, but I realized pretty quickly that I just didn't like the job as much as I thought I was, and as much as I liked working in labs during my undergraduate program. So I decided that I would start applying to master's in public health degree programs because I knew I wanted to work in healthcare, and I thought that that would be like the most flexible degree since I didn't know what type of job in healthcare I wanted to have. And then around the same time that I was applying to MPH programs, my little brother was diagnosed with schizophrenia, and so I left my lab job to be home and help care for him. And when he started doing a lot better, I also got my acceptance to the Boston University School of Public Health. So I knew that I was going to be leaving in September for that. And at this point, it was like March. And so I had quite a bit of time in between there to kind of just like do anything. And since my brother was doing better, I was like, okay, maybe I'll get a part-time job. And I got a job working at a community center that was providing case management type support to low-income individuals with really serious mental illnesses. And I took the job mostly because I was so new to having a loved one with schizophrenia that I was just like, I need to learn as much as I can about this. And I did learn a lot about schizophrenia at that job and a lot of mental illnesses, but actually the main thing that I learned at that job was how difficult it was and how expensive it was for low-income individuals to navigate the healthcare system. So like my brother was facing a bunch of challenges and barriers, but we were like financially stable as a family and were able to provide him with support. But people who didn't have financial support or familial support, they were like really kind of left to themselves and didn't have a lot of options. And I had clients that I was trying to help that like were denied from various providers because they had medical debt. They had like court mandated inpatient stays that they had to go to, but then they would get a bill from the hospital that was like really large because there was like an error with the insurance and they didn't know what to do. So there was just like a lot of debt that people were dealing with. And I realized pretty quickly that it was because of the way our policies were set up. Like a lot of my clients knew a lot about health policy, more than I ever thought people should have to know about health policy. And so it honestly just broke my heart and made me really angry. And I decided right after that job that I was going to focus on health policy when I got my MPH at BU. And I mean, there's a couple more steps in between there and me working at Healthcare for All, but mostly since then, I've been dedicated to working on healthcare affordability.
I have a kind of weird background story. So basically, I kind of was really ignorant about policy growing up. I actually just never thought about it, never thought it was important. During undergrad, I was just straight pre-med, just thought, med school, and that's pretty much it. And so because of that, I was a first responder, and just to gain more clinical experience. And I realized a lot of my patients had a lot of financial problems. A lot of them didn't have insurance. A lot of them didn't even understand insurance. There was a lot of legislative barriers that prevented them from accessing healthcare. So it wasn't even just like healthcare itself, it was just all these legislative barriers that even I didn't understand. So I couldn't even provide any sort of support to my patients because when they talked to me, I was like, I don't know what to do. So that's what actually drove me to Young Invincibles because the they have this program, the Youth Advocate Program, which I was referring to earlier, and I joined that. And that was kind of my first step into policy, into like healthcare policy. And I realized there's a huge gap between healthcare and like legislative problems. And I saw there was this gap that needs to be filled. So that's what actually drove me to keep going through Young Invincibles and learning more about policy. I even helped actually pass a bill 2 years ago to mandate itemized billing because itemized billing is basically just receipts for your medical bills, just to give patients more autonomy and more rights and like teach them how to lower this medical debt for them. And so basically that kind of led me to policy and led me actually pursue a graduate degree in it. And that's why I'm here now because of that.
So I think, yeah, I've always had an interest in public health. So I studied public health at Hopkins and I was living in Baltimore and I'm originally from Los Angeles. So I think living in Baltimore, you can just really see just disparities everywhere you go. I spent a lot of time in Baltimore working at healthcare for the homeless. And so a lot of people didn't have not just access to healthcare, but just like respect and dignity as people. So did a lot of homelessness work in college and then I knew I wanted to continue studying public health, so I went to Cambridge in the UK and got my population health sciences MPhil. Um, and at that time, I mostly was focusing on sort of the digital gap and understanding how people in more vulnerable communities don't have access to digital literacy, which then didn't give them access to healthcare and employment and all of the things that became a huge cycle for people to stay in poverty. Then when I came to medical school, we have a really unique program here where 12 of us rotate during our clinical rotations at the Cambridge Health Alliance, which is a safety net hospital located in Cambridge. And part of our clinical experience, instead of doing block rotations that everyone does, you follow a panel of patients longitudinally across their healthcare journey. And so I had a lot of patients that were on my panel, like a primary care doctor has, and I would go with them to all of their outpatient visits, whether it's their PCP, their neurologist. If they were diagnosed with cancer, we would go to their oncology appointments. We would be scrubbed into their surgeries if they needed surgery to remove breast cancer or colon cancer. And I think through that experience, you really understand the healthcare system. And one of the biggest things on people's minds is how much their healthcare is going to cost. I distinctly remember I had a patient who kept trying to leave the hospital, even though we were treating her and she needed to stay. And as we continued to ask her why she really, really wanted to leave against medical advice, is like something that we call it AMA. She revealed to us that she was choosing between rent and the medical bill that she was going to get. And she would rather have rent because she like had a cat that she really, really loved. And she knew that she'd rather be housed than whatever sort of healthcare problem that she had. And I think it's just like so revealing on a day-to-day basis how burdensome the financial stress that people experience with medical debt and just medical stress, financial stress occurs, which is then how led to me working on Understanding financial transparency in healthcare, it's still impossible to figure out how much your bill is going to be or like how to shop to which hospital that you should go to. So I worked on a small project on that, which then led to the project that I'm now working on with Ria and a resident here, David, where we're trying to understand the financial assistance programs that can sort of fill in the gap for patients who do have this financial burden.
So, from your experience, what's something crucial you've learned about medical debt or healthcare access that wasn't taught like during your schooling?
Um, I think I think one thing is that there are like people have legal rights. And I think a lot of times people don't think of debt as a legal issue when in fact it is. And part of my job is just telling people, you have the right to do X, Y, and Z. Like if the hospital doesn't follow through, we'll help you through the process and you have, enforceable rights. Um, a lot of that's can be later, like if the hospital's suing over medical debt, there, especially in DC, there's lots of strict requirements about how they can sue you and what kind of documentation they have to provide. But also if medical debt's on a credit report, you have rights related to that and disputing inaccurate information. And a lot of our policy work right now is creating laws within DC to have more enforceable rights. Like right now, DC doesn't have any specific laws related to financial assistance, but we're trying to require hospitals to provide financial assistance to people based on certain income, eligibility, having a uniform application, all these types of things that if when we get those rights, we'll have further legal levers to enforce them and help people prevent or not be as burdened with medical debt.
So I think one of the biggest things that I learned working in this job on medical debt. Actually, let me back up. So, Healthcare for All has a direct service team. We have a helpline that helps people get health insurance coverage. And then we also have a community engagement team that's like really out in the community, learning from communities and making sure that the communities that have been like notoriously under-resourced have the resources to help their community members get coverage and access to care. And as the policy team, we really try to learn from our helpline and from our community engagement team on what is going on with actual people and how they're facing these challenges before we craft any of the policies that we are putting forward. And one of the biggest things that we learned during that initial conversation with our other teams was that a lot of medical debt actually comes from like mistakes, essentially. Like we learned that like sometimes there are like language barriers that lead to providers taking down somebody's name wrong or like spelling it wrong, and then the provider can't bill the insurance correctly, or somebody is kind of in crisis and forgets that they actually have two insurance plans. And so they don't provide both. And so they're underinsured at the time that they get there. And I think realizing that kind of like changed a lot of my perspective. Like these aren't things that we're passing laws necessarily to fix. These are things that either within state administrations or within hospitals or different organizations, we can make like smaller administrative fixes too that would like really impact people's lives. And I think that was definitely one of the most eye-opening things, because I think I took this job being like, okay, I'm going to pass some laws, I'm going to force everybody to do these things. And actually it's been like a lot more, well, we're definitely trying to pass the laws, but also the other part of my job is kind of focusing on this administrative agenda that really requires a lot more like relationship building and meetings with stakeholders to kind of learn what their process is and see if we can be helpful in like changing some of the steps to like eliminate some of those mistakes.
One thing I've learned for my job at Young Invincibles is I've been more involved recently because of the past legislative session. I've been really involved with legislators and trying to talk to them about like different bills or just trying to deny a bill and things like that. And also helping people testify and coaching them on what to write when they're going up to testify. And one thing I've really realized is that stories are a lot more powerful than statistics. I've talked to a lot of congressmen and legislators and talked to them about like giving them facts like, oh, this many people suffer from medical debt, this many people do this, and stats and figures really don't really get that far and get that through to them. when you have someone and you have when you galvanize a story and you present it to them, that's a lot more impactful and reaches them in a more humane way. So every time I coach someone in testifying and tell them what to put in, I make sure to emphasize their own story rather than these like statistics that more so dehumanize the situation. So that's one thing I kind of learned. Like Serena mentioned, having someone choose between rent and medical debt for like cat. So things like that drive more change a lot more than just stats and figures.
I think that something that I've learned is that any touch point and I do a lot more clinical facing work, so I feel like my takeaways are mostly clinical, but any touch point that a patient or person has with anyone is an opportunity to like serve them. And so, they could come in and social work can see them, or a specialist like a hematology can come see them, or even a medical student, I feel like sometimes, or a volunteer at a hospital can come see them. Um, I feel like people in training often don't think that they have the power or the agency to make that kind of change in someone's life. But a lot of the times, I think any point of contact anyone has within the healthcare system is an opportunity to understand what kind of services they need, what are they really stressed about, and like how can you help them. And I think I've learned a lot of really, really small things that we can do as healthcare providers from people who have these same values and missions. So, for example, you can order medications to the bedside if they're inpatient so that you don't have to wait for them to go to the pharmacy and then not be able to get to the pharmacy and not get their medications. You can contact social work earlier so that they can get access to different at-home services. And I think just approaching patients with a lot of curiosity and recognizing that maybe you do have a defined role and it might be a clinical role, you're still able to ask them about who they are and like what they care about and what their goals are so that you can also shape your clinical care, but also provide and become aware of the services that you can provide as a healthcare institution.
Have there been moments where you've felt your work directly changed someone's experience with the healthcare system? And if you feel comfortable, would you mind sharing a little bit more about that experience?
A lot of my clients also have nursing home debt, which as a form of medical debt. And I had one like 88-year-old client who was sued for over $100,000 from a nursing home for her treatment there. Part of it was during COVID, and so she wasn't allowed to leave or get out as early as she would have otherwise. But she was very concerned about losing her home to COVID, and she had some like lasting mobility issues. And so I worked with her to represent her throughout the court case. And we ended up settling for like less than $30,000. So something still a lot of money, but way more affordable for her, and something that, she could pay off with her estate and she didn't have to focus on paying off with her current um, income. But part of my work was also getting her to trust going to the doctor again, because after that, every time I'd talk with her, we talk about she was 88. She had a lot of health issues. But she'd say, oh, like, I'm never going to the doctor again. And so part of my work was just, why is that? Like, oh, you definitely had a horrible experience at this one nursing home, but not everyone's like that. Like, can we work to find a provider that you're comfortable with? And, I went with her to some community-based health centers to help her get care. And she's really focused on getting her patient bill of rights every time. And so I think, just having a sounding board, and I was a trusted individual for her since I worked with her for so long and so closely. And by helping expose her to different doctors, different places do things, it helped her become more comfortable with accessing the healthcare system again.
So I don't know that I have a direct like client story to share because it's kind of one of the downsides to policy work is that it takes forever to do. And so the gratification of like helping people comes like a lot later down the line. And even if you do pass things, it's like then we're in implementation mode because sometimes things don't get implemented the way that you want them to. So yeah, I don't know that I can share any like positive stories from our policy work at this point since it's so new, but I will say like we Healthcare for All as part of this project is sub-granting to community-based organizations that are trying to help clients with medical debt and then making referrals to legal assistance when needed. And we actually just did some site visits with our community-based partners, and they were just so grateful for the project and so enthusiastic about the second year of the project because they had had clients that were coming to them just in very enthusiastic about the help that they got from helpful advocates or from some of the people at the community centers that were working on this project with us. And that was like really heartwarming to hear because we get a lot of like data and numbers from our community-based project partners because they're reporting to us, but we don't a lot of the times get to see, the reactions to it. And so it was good to know that even if the policy side is kind of delayed in helping people immediately, our community-based partners and our other partners on the project like Undue and Health Law Advocates are definitely making a difference, and we're definitely hearing about it.
I've had a couple of really good interactions, like from a one-on-one perspective. So I used to be part of the community engagement side of Young Invincibles, and that's where we kind of hosted literacy sessions for student debt and health insurance because it was like a little complicated. So we just hosted these sessions to kind of make it more digestible for people. And during those sessions, I've had multiple involvements with individuals who want to meet after a literacy session to talk more. So I had this one girl, she was an immigrant from Colombia and she just came and she was uninsured, and like, to be honest, I could tell why. Like, health insurance marketplace is very confusing trying to like shop for health insurance and things like that. So I met with her after one of our literacy sessions and we fired up the open marketplace, and I talked to her about like deductibles, co-payments, all that, and like went through and through trying to explain every single part of it and what she's looking for and all the different payment plans and things like that. And I luckily was able to find her one, and she was enrolled, and it began in 23 days because it was during the open enrollment period. So this was also after I was an EMT where I wasn't able to help people. So being able to actually like make a change and like help someone get insurance was definitely like very, very nice to see.
I had a patient just last week who had a very gangrenous gallbladder, and for days I had been seeing her and she would just say she's not in pain, and she was like basically my mom's age. And I think with time she started opening up and then revealed that she was experiencing a lot of financial stress because she was the breadwinner of her family. And when we offered her different services, I think she was very, very hesitant, understandably so. And I think something that we were able to do was to sort of coordinate with, like, she basically denied a lot of social services due to having the proper documentation, and we were able to coordinate seeing if her daughter could receive those services in place for the entire family. And I think that it felt like we were able to give her another option when at times she felt like that was the only chance she got, or that she couldn't do anything about the situation that she was in. And while we were there to provide her medical care, we were also there to best serve her in whatever way that she needed. And I think ultimately she was able to receive more support at home. And I think she was really, really grateful for that. And I felt like we're also very humbled that she would open up in that way to us and tell us something that she is understandably really fearing right now.
Going on to like our more tailored questions, I'm going to start with Jennifer again and then go around that loop. So Jennifer, as you mentioned briefly before, you work directly with low-income DC residents dealing with medical debt. What patterns or reoccurring issues do you see in how debt is created or enforced? And how do you think those kind of reflect systemic failures in healthcare and consumer protections?
Sure. I think one of the most common things I see is that patients just don't know financial assistance is available. I've seen that in pretty much all of my clients who have medical debt. No one knows that that's even an option. And so honestly, a lot of times I help them apply for financial assistance, it's approved, and then, they move on, their bill's eliminated. Um, I think that's really a systemic failure from the hospital, and also that the IRS doesn't really enforce any standards on nonprofit hospitals and how they need to publicize these. Even if it's in a bill or there's like a small statement on a bill that says financial assistance may be available, most people don't think that it applies to them, especially if they have some sort of form of insurance, or if they're at or above 200% of the federal poverty level. So I think that's probably the biggest one. I think there's also a big threat with medical credit cards these days. Those are credit cards that are offered at like a dentist's office, a specialty office like an ophthalmologist, somewhere like that. I've had patients who show up to receive care. They may have been told that financial assistance is available for the care even, and then when they get there, the only option is to sign up for a medical credit card. And it's promoted as something that has no interest, which is true for the first year. But then if they aren't able to pay off the full balance within that year, then it retroactively applies interest to the full amount. So patients are hit with really high rates of deferred interest and often feel really coerced into taking out these products, especially like they're at the provider's office already. And I've had patients who've been told, like, you have to sign up for this credit card or I won't see you ever. So that's a very coercive tool. That's really a systemic failure, and that needs a lot more regulation. We, in the previous administration, did some work with the Consumer Financial Protection Bureau to see how they could help regulate that, but that's not going to happen again for at least another 4 years. And that's an area that states can't strictly regulate. It has to be the federal government, but we're trying to, make some policy changes in how those cards are promoted to weed out some of the worst instances.
So, Marcella, your work with Healthcare for All spans research, advocacy, and coalition building. What role do you think community-based organizations play in addressing medical debt and affordability reform? And how can state-level efforts better support their on-the-ground work?
Yeah, so this is a great question. So I think community-based organizations notoriously get left out of policy discussions a lot of the times, and it's really like a downfall of our system because they have some of like the largest amounts of knowledge about what their communities are really struggling and facing. And I think something that we're always trying to think about and work on at Healthcare for All is making sure that we're like uplifting the voices of our community-based partners and allowing them to have a seat at our table when we're talking about advocacy and policy decisions that we're trying to get the state to move forward with. And I think that's mostly because they are the ones that are providing support to clients, even if they don't have like lawyers on their staff that are doing some of that legal assistance work. They are often just trying to help them in any way they can. They'll be the ones calling the doctor's office to be like, are you sure this is the amount of the bill? Like, can you send me the receipt so that I can check with my client to see if this is like actually the service they got? Or they'll call the insurance provider and they'll be like, are you sure you can't cover any more of this? Like, they're doing that work because they're some of the most dedicated workers that I've ever met, and they will stay late and they'll go above and beyond for their clients and their community. So I think involving them at the table is one of the biggest things that would help, I think, as we're like thinking about policy and making sure that the policies we're trying to implement aren't just like research backed, but also like community and patient and client backed. And then I think also making sure that we are partnering with our state agencies to ensure that they know that they can use community-based organizations as a resource and that they can subgrant to them. So not as part of the medical debt project, but as part of our another project that Healthcare for All works on. We have partnered with the state Medicaid office, and they help fund what are called certified application counselors in Massachusetts. And this was really like the Medicaid office had the certified application counselors before, but they were a little bit less accessible because they weren't in these community-based organizations where people are already congregating and going for other day-to-day needs that they have. And so the CAC program is really to help drive up the resources that those community-based organizations have so that they can hire people who would get certified as application counselors, and then also continue to like advertise and promote and educate their community members that these resources are offered to them. So I think it's really twofold. It's about uplifting their voices, but also making sure that they have the resources to support their community when their members are coming to them and asking for help.
So, Hadi, given your involvement in federal and state advocacy work through shaping Young Invincible's policy agenda, as well as helping lead legislative efforts for SB 490, which, as you mentioned, was a huge step forward in billing transparency in Texas, what did you learn from that process about how policy can realistically address medical debt? And where do you think future legislation still needs to go?
Oh, that's a great question. I learned a lot from this experience from a policy perspective. First, I want to address for future legislation, there's a lot that needs to be done in terms of where we need to be and where we are. Obviously, the type of healthcare program we have now is very privatized, and there's a bunch of systemic problems like insurance companies and things like that. A lot of physicians nowadays also practice more like medicine based on like making sure they don't get sued and things like that from what I've seen. I've shadowed a couple of physicians as well, and they seem to be more focused on referring them to other specialists and things like that, just trying not to get sued and things like that because of the policy that we have right now. And from what I've learned from a policy perspective from what I've been working for the past few years is that a lot of these congressmen and legislative people that are in office right now, they don't know the healthcare system. And that's why we do need medical professionals and or like people who can advise them on what's going on in the medical field. Only 4%, I think, of congressmen are physicians, and these are the type of people that are making judgments on the full healthcare bills. It's people who have zero experience on the healthcare system. So I think there needs to be a huge systemic change when it comes to how this policy works in general. But obviously, these are things you need to take in a one step by step every year, take it one step at a time type of change we need to do. But I think it's great that there's a lot more, I guess, awareness to the healthcare issue, and a lot of people are realizing that it is a systemic issue. And slowly, more people are being involved and calling their own congressmen and telling them their own stories. So I think this is definitely, once again, like a huge issue, but it's slowly getting better and better with people being more involved.
And then, Serena, as a medical student working at a safety net hospital, you see firsthand how financial stress affects patients. How do you navigate those tensions in clinical care? And how has that shaped your understanding of what it means to advocate for patients both inside and beyond the clinic?
Yeah, that's a really good question. I think that um something that always comes to mind is one, being able to look at patients as to who they are outside of their clinical diagnoses. So understanding, always asking them like where they live, who they live with, if they feel safe in their home, who their partners or community support is. You'd be just so surprised by saying that you're a medical provider. People will confide in you for no real reason other than that they just trust you. And so they'll tell you a lot of things that in some cases they've never told anyone in their life. And so recognizing that privilege that you have as a frontline healthcare worker is something that's really important. And then really knowing what services and just like resources you can provide. So getting to know your case managers, your social workers, and asking them, what are the things that you can provide for patients? Because then when you interact with them, you can ask them if this is something that they need. Because if you don't ask them, then no one will ask them, and social work will never get involved in their care. And like I said earlier, there are small things that you can do, like picking a drug that is less expensive, prescribing it to a pharmacy that is less expensive. You'd be surprised at the price range at just like different pharmacies. And being able to really, if a patient's not taking their medications, ask them why. Is it because they can't afford it? Is it because they can't get to the pharmacy? Is it because they don't understand why they're taking it? And so as a clinical provider, you just have a huge, I think, responsibility to get to understand what is motivating and driving patients to do what they do for their healthcare and how are their social stressors impacting their care as well.
One last question to kind of round out this first segment of the event. But what's one action you'd encourage everyone here to take after today's conversation?
Contact your congressional representatives about the big, beautiful bill and the impacts on Medicaid and healthcare cuts.
Yeah, I'm gonna have the same answer, but I'm actually gonna make a shameless plug for something we're doing at Healthcare for All because we just recently partnered with SEIU, which is like a national labor union organization, to create a phone bank because we have a lot of untapped energy in Massachusetts because all of our Congress people are Democrats. And so we created this phone bank with SEIU so that we can target voters and constituents in key congressional districts to have them call their legislators and let them know that they should vote no on Medicaid cuts, which are currently making their way through Congress and would result in like millions of people losing health insurance and also lots of people then having medical debt. And so if you want to get involved, I'm going to put the link in the chat so that you can sign up for the phone banks. They're super fun. We're Healthcare for All is always on them. There's like a training to them, so they'll like walk you through all of the steps, but it's like a great way to get some of that energy out. If you're feeling a little bit hopeless, it's a good place to kind of get some of that frustration out and to be surrounded by people who are trying to do the same thing. And we're running them until the end of June. There might be an extension, but for now, they're until the end of June. And if you join the ones tomorrow, there will actually be a special message from Senator Warren. So I'm just going to put that plug there. But yeah, definitely call your Congress people, let them know no cuts to Medicaid.
Yeah, honestly, I agree with the previous two panelists about the big beautiful bill, especially. But honestly, just start learning. Policy is very macro. There's a lot to learn. There's a lot of different levers. There's many organizations like Undue Medical Debt and shameless plug-in Young Invincibles. So honestly, just reach out, and I know there's plenty of us who are in the field already that would love to teach and get more provide you opportunities for you to be involved. There's plenty of ways to get involved. You can either do calls, you can either just host sessions and just teach people about policy, about what's going on. There's just a lot of different ways to be involved. Just reach out to just any organization, Young Invincibles too, and there will be some way to get involved.
Yeah, I have similar advice. I think take action. So if there's a problem that you see in the community that you're in or wherever you're working or residing, recognize that you have agency and are empowered to be able to take action on that. And whether that be I think sometimes the hardest thing is just like sending that email, right? Like reaching out to that person and starting that conversation because it might be in your head like, oh, that's a little bit weird or like that's like so frustrating, but then never really doing anything to fix it. Send an email to that person and then ask that person who to connect you to next. And then I think that sort of gets the ball rolling.
We're going to go directly into just a Q&A. So if anybody has like any questions, specific questions they want to ask the panelists, or if the panelists want to ask each other, you guys can raise your hands like using the feature within Zoom, or you can just put it in the chat and then I can read the question out loud. But if anybody wants to start off.
I have one for Jennifer. You mentioned how a lot of patients don't have financial or don't have like knowledge of financial assistance programs. How do you feel like hospitals can do a better job of educating patients or like finding specific patients too who would really benefit from these programs and then like helping them apply to these programs?
I think trying to put the onus more on hospitals to let patients know about it. And so, if you're including information about it in whatever like intake process you have, that can be really helpful. I know Colorado has some new laws that require something like that. That's been pretty successful. Um, and also having presumptive eligibility. And that is when anyone who receives any sort of mean tested public benefits like SNAP, food stamps, housing assistance, anything like that, as soon as you know that person has those benefits, then they are automatically eligible for financial assistance and they don't have to complete the whole application process. They can just show, like, I don't know, their SNAP EBT card, like they could show some proof of a housing voucher, something like that. And so it's just a lot easier for them to apply. I think those would go a long way in helping patients know about it.
Rose, go ahead.
So Serena, I'm just curious, what do you think the mood of your fellow med students are in terms of affordability and entering the profession? I mean, I can tell you're very dedicated and had a clear mission going in, but what do you think about your classmates and as they enter the profession, what are they talking about?
I think that we recognize being in Massachusetts, a lot of our patients have Mass Health, which is a huge, huge difference in the care that we can provide. But I do think it is very frustrating for a lot of us. And when we, prescribe medications and patients aren't able to afford them, that's really frustrating. I think there are a lot of like qualms that we feel with the hospital systems that we're in, and also just the policies and also the impending doom of Medicaid being cut. I think we definitely feel it all. I think, we find ways to feel hope. And I think one thing last week my attending was telling me, we can show up to work and we can do our best today and take care of the patients that we have today. And also recognize the power and the privilege that we have here at Harvard to, when we do speak up, people do listen. And that's a responsibility that we have, and not to, in some ways, like let it go to waste.
I have a question. This is for anyone, but I mean, I feel like we all know like the current political time is, I don't know if you'd say atypical, but I mean the past 5 years and then looking forward for 5 years, like do you think you're going to continue dealing with the same challenges you do right now, or would it develop into something different if, the Medicaid changes or, if something happens in the midterms?
I think, prior to this federal administration and the proposed cuts that are working their way through Congress on Medicaid and ACA plans and everything, I think, we were focusing a lot on like state related fixes, things like hospital financial assistance programs. Massachusetts, for context, has like the lowest uninsured rate in the country. So I think it's like only 2% of residents in Massachusetts are uninsured and don't have health insurance. And so a lot of our state fixes were, we were kind of thinking in a way that would move slightly away from trying to get people coverage, because it's like mostly accessible here. But I think that if a lot of cuts come to Medicaid and a lot of our residents start losing coverage, we will have to go back a couple of steps and try to figure out how to get people back on health insurance coverage. Because I do think that is one of the best ways to make sure that people don't have medical debt. And if we're living in a world where people can't get insurance coverage because of red tape and work requirements and because of their immigration status, I think we're going to be living in a much more expensive healthcare environment.
I just want to give another perspective to that question. Texas actually has the highest uninsured rate in the United States, not to brag, at least number one in that. Um, so I think also just a problem for us, I don't know how it is in Boston or Massachusetts. A problem for us is no one really understands or gives kind of due credit to kind of like how important health insurance and medical debt really is. It's kind of in the backbones of everything, at least in Texas legislature. So I think just in the future, or depending on our future political climate, I think there just needs to be more emphasis on health insurance and medical debt, at least in Texas as well, because when there's budget cuts and things that need to be cut, the first thing that's always cut is Medicaid. And we already have a highest insurance rate, and it just progressively gets worse because no one really understands, or no one really even like cares and tries to protect medical insurance, and which kind of leads to more medical debt.
I think the onus is definitely on states now to do more. Prior, I've been part of some coalitions that were kind of game planning if 2025 goes a different way, like what are we going to ask from the CFPB, Consumer Financial Protection Bureau, the IRS? Like there's a lot of federal levers to pull if it's a friendly administration. But now the focus is just on states. What can states do themselves to implement better protections for folks? I also think we'll see a lot more collection efforts, just with more people having medical debt in the future after all of these cuts go into effect. I think having more protections on like preventing abusive collection actions and trying to mitigate harm from credit reporting, things like that will be much more important. Because having medical debt on a credit report, can make it more difficult for someone to get a job, to get new housing, to get other lines of credit. And so if there's ways to mitigate that burden, even if people still have the underlying medical debt, that can help, with their mental health, their physical health, their financial health, and then eventually help them pay it off as well.
I have a question for Serena. I just finished my first year at Downstate Med, and we also serve a huge, like, low income and heavily underinsured population. And a lot of what they teach us in terms of learning how to interview a patient, I feel like social history kind of gets glossed over sometimes because it's kind of like at the end, it's like, oh, drugs, drinking, sex, your diet generally. Do you have a specific question or phrase that you tend to turn to when asking a patient about their insurance and how they feel regarding their medical care, just to make sure that you hit that point in the interview?
Yeah, that's such a good question, and congrats on finishing your first year. I think that one is like a lot of interactions with patients take time to build trust. And so a lot of the times people won't share things until they trust you, which makes sense. But that takes a lot of time and effort. And I think on first interaction, you can sort of establish that you will care for them as a whole person by like what you said, like spending more time on social history. I used to be a hater of like small talk. It just like did not come naturally to me, but I realized just how important it is to build rapport with people by asking them like, "Oh, like I see your dog is on your phone. Like, can you tell me about your dog?" And I think this gets lost in medicine so much because people are constantly on the go to the next patient. They have like a bunch of tasks they need to do. But that is the true joy of being a medical student, where like you have responsibilities, but like they're not really your responsibilities because it's like the resident and the attending's responsibilities. So what you can do is you can spend more time getting to know people. And then like how to phrase certain things. I think when things are really, really sensitive, I'll always just say like, I ask this of everyone, and this isn't specifically targeted towards you at all, but for like substances, like, are there any substances that you use? And then be as specific as you can. Or like, are there any stressors that you feel? And be specific. Like, is it specifically food? Is it, and like, how are you getting your food right now? Do you have transportation to the grocery store? How are you currently making your meals? Like, really probe into people's lives. And I think when you come from genuine curiosity, people don't take offense to it at all. And then like sharing a little bit about yourself when appropriate, right? Like, oh, I love eating that. And then I think it just like people really do come to open up to you.
I have another question, but for Jennifer, I was wondering if you got your experience from, or like, your health experience or interest in law school, or if it came from other experiences you gained in your journey to your current position.
Yeah. So after college, I served as an AmeriCorps Vista for a year. I lived in Austin, Texas, actually, and worked at a nonprofit doing food insecurity work for after-school time programs for kids. And then I went to grad school for social work first, actually. Um, and I worked at a foster care agency. I worked with a collaborative that tried to bring more healthy foods to like corner stores in different neighborhoods. And for me, the center of all of that was economic equity. Um, but I was part of the Trump bump in 2016 applying to law school. I just felt like you have a lot of influence with a law degree, similar as with an MD. And I just felt like I could do a lot more with that degree than I could with a social work degree. Different levers are open to me. Like I can go into court and defend clients. I can just go to the hospital and like be their patient advocate. We do a lot of just community outreach and education that, I don't necessarily need a law degree for, but it helps in certain aspects. So I feel like it's pretty flexible for that. And then, like, my work specifically falls into consumer protection, like more broadly. So our office also helps people with like victims of scams, if you were defrauded by a company, just if you have credit card debt that you're trying to settle, we do all that types of work. I didn't do a lot of that specifically in law school, but was at a lot of different nonprofits. And yeah, I think just focus on different aspects of economic equity, like housing, food, medical debt now, all kind of get at the heart, like people don't have money to go around and where are they going to spend it and how are they going to prioritize it? And, how can we help eliminate some of that debt burden for them in different ways? And at my job specifically right now, I love that I can do both direct services and some policy advocacy. I think I've been in roles before where it's just direct services, which is awesome, but I also have felt like I'm just, putting out the same fire every single day and not making any change to it. And then I've been in other policy roles where, it takes a long time, but you eventually get those policy changes to make that change. But I'm not seeing the impact on people. So even though I know it's rewarding, I like the direct client experience. And also, I just feel like, I see patients on the ground who can't access financial assistance, and then that informs the policies we're proposing here in DC. So I think it's a really good cycle, and I'm happy that I ended up in an org that allows me to do both.
I just want to jump in here really quickly to ask if everyone could put their contact info in the chat so we can share it with everyone later, just for networking purposes. But like, keep asking questions.
Marcella, if you wouldn't mind speak, just because I was curious, also just how you get places where you're working. It's like, can you speak to the what you've leveraged as right your public health background, especially like I feel like healthcare is sector I work at Undue, but like I feel like the healthcare sector has varying. I don't have an MPH, right? Like, but we worked, full disclosure, Marcella and I have worked together, collaborated together. So could you speak to the value, like where you've come, like you talked to us about what led you to the MPH, but could you tell us about yeah, ways that you've flexed it in the work that you're doing?
Yeah, definitely. So I would say like a master's in public health program is like way different than like a bachelor's degree. Like they really, at least at the BU School of Public Health, they're trying to teach you the skills that you need to work in whatever area of healthcare that you're trying to work in. So like the classes themselves are much more tailored. So for example, I took a class on like um community organizing and campaigning to make healthcare changes. And as part of that class, you had to do like 6 hours a week with like an organization that was working on a healthcare campaign. And as part of that, I was working with one of the professors at the BU School of Public Health on like a campaign to um, increase the tax on alcohol in Massachusetts, which like hasn't been increased in like a very long time, and it's not a like popular thing here in Massachusetts because Massachusetts has like a lot of ballot reform initiatives that come up, and it was on the ballot one year and it wasn't voted for, and so there's like no political will to do it basically, but it's like research shows that it's one of the things that decreases people's consumption of alcohol the most and leads to like good health outcomes. So like I was working on that, and then also when you get your MPH you have to do like a practicum, and so when I got there, I knew that I had no health policy experience, and I really wanted my practicum, which is basically like an internship for anybody that doesn't know, and there's like a set number of hours. But I wanted it to be on policy because I didn't know for sure that I would actually like that job, and I knew coming out of my lab job that like I could think that something would be a good job and then not actually like doing it. So I got like unpaid internship at the Massachusetts State House with a lawmaker who used to be a psychiatric nurse and had a lot of bills that she was putting forward related to healthcare. And she, as part of her internship, because a lot of interns at the Massachusetts State House are like the ones answering the phone and doing constituent work, which like is also very important and teaches you a lot about what's going on in healthcare, but is definitely something that like some of those offices might think is like grunt work that they don't want to always do. And so they put it on interns, and the lawmaker that I was working for really wanted her interns to have like real experience. So she would like put us in contact with everybody she knew in an area that we were interested in. So I came in obviously being very interested in like mental health, and also I had like criminal justice interest, kind of like the intersection of those two. And she was putting me in touch with people at like the Department of Corrections and at various hospitals and different like random med school students that she also knew. Like she was connecting me with anybody. And at the end of that internship, you had to write a bill, and she would kind of walk you through the steps of what that looks like and how that works. And I came out of those two experiences, that like class on campaigning and my internship at the State House, with like a lot of skills, I would say. And it was something I wasn't really expecting because my Bachelor of Science degree, it's like, yes, I did research as part of classes and stuff, but I had to like go seek out other experiences, and like a degree in public health kind of just forces you into those experiences. It's just kind of part of the program. And I think that was one of the biggest things to leverage, because I think there's a lot that you can do on like research and reading about topics and having like a general interest in a topic that is also important for the job. Like I think coming in and knowing about medical debt and having thought about it and had experiences with people with medical debt like definitely set me apart from other candidates, but it was also like having experiences that developed skills that would be useful. And I think that's kind of like my biggest tip is like, yes, the degree is important, but you can also get those skills by like doing a part-time job or doing an internship or volunteering or coming to the phone bank. So like all of those things are helpful. And if you can find a way to leverage skills that you already have, definitely do that.
All right, so if nobody has any more questions, I think that we can wrap it up here. Thank you so much again to our panelists for coming and speaking with us today. Um, please feel free to take down everyone's contact information, like that's in the chat. We'll also send it out later, as well as all the other links that have been put in the chat. Well, thank you so much, everyone, for coming, and I hope you guys all have a great rest of your evening.
Thanks. Have a good night.
Thanks, everybody. Bye.